Welcome to Loyola University Chicago's Be the Change Implementation Science Seminar Series. The Parkinson School of Health Sciences and Public Health, Loyola University of Chicago, in partnership with the Institute for Translational Medicine, offers monthly seminars to promote implementation science to improve translational science and health outcomes. Our guest speakers are researchers and practitioners in implementation and dissemination. From different lenses, we will learn about theory and use cases. This is hosted by UT Southwestern's Dr. Timothy Hogan, titled Engaging Patients Through Technology, Advancing the Intersection of Consumer Health Informatics and Implementation Science.
It's my pleasure to introduce Dr. Timothy Hogan, who is an associate professor in the O'Donnell School of Public Health at the University of Texas Southwest Medical Center. He is also the director of the Department of Veteran Affairs eHealth Partnered Evaluation Center, multiple PI of VA's Virtual Care Consortium of Research and research health scientist with the VA Center of Healthcare Organization and Implementation Research. Dr. Hogan's program of research encompasses three broad areas: consumer health informatics, implementation of interventions to improve healthcare delivery, and management of patients with complex chronic healthcare needs. He is passionate about information and communication technologies that are designed for patients, caregivers, and clinical teams, and how those technologies can best be implemented into practice. His funded studies have focused on individuals living with complex chronic conditions and how they access and use healthcare information, as well as the implementation and evaluation of consumer health informatics applications, and to support patient engagement and self-management. I will also say that once upon a time, Dr. Hogan was my research fellow at the Hines VA. So I am absolutely delighted that he has surpassed me in so many ways, and he's here to present today. Tim, over to you.
Dr. Weaver, thank you for that. I have to fight the urge to call you Fran, but Dr. Weaver, thank you. And I will say that it brings back a lot of good memories to be presenting at Loyola, in addition to my fellowship training at Hines and my first investigator position at the VA, being at the Hines Center of Innovation. My first faculty appointment was also at the Loyola School of Medicine as well. So it's great to be connecting with you all today. And I really appreciate the chance to tell you a little bit about some of the work we're doing in the VA focused on virtual care implementation. So just as I get started here, just a couple of statements about funding support and disclaimers. So the work that I'm going to present today is work that we've done as part of our eHealth Partnered Evaluation Initiative that Dr. Weaver mentioned in the VA. And the viewpoints that I'm going to express are really mine. They are not necessarily the position of the Department of Veterans Affairs or the federal government. So in terms of goals for today, these are the points that I really hope that we can cover. So I'd like to start by talking a little bit about virtual care technologies and the significance they're playing in contemporary healthcare. I think we probably all have some thoughts on this given the ongoing COVID-19 pandemic and what we've seen in the uptake and use of virtual care technologies to support care during the pandemic. From there, I'd like to talk with you about some of the VA's latest virtual care initiatives that are ongoing. And then I'd like to spend a little bit of time trying to reframe and think a little bit differently about some key issues that are part of any effort to implement and evaluate virtual care technologies as part of healthcare. And then with that kind of background in place, I'm going to turn my attention to two virtual care implementation projects that we've recently completed in the VA. I'd like to share those with you. And then with the time we have left, I'd love to answer any questions, but to also hear from you all if you have interest in thinking about the implementation and evaluation of virtual care technologies. So when I give presentations like this one, I oftentimes like to show this tire swing cartoon. And I think it's really effective at conveying the many varied perspectives that stakeholders can bring when implementing a virtual care technology into care, and the complexity of the work that's involved in implementation when we have multiple stakeholders involved. And, as you take a look at this cartoon, as you step through these panels, so, first we have a technology that was proposed by a project sponsor. It looks like this. It was specified in the project request. At that point, it looked like this. When it was designed by the senior analyst, it kind of took on this form. When the programmers produced it, it kind of looked like this. When it was actually installed at the user site, kind of looked like this. But at the end of the day, what the user really wanted was this sort of traditional looking tire swing. But again, kind of an amusing way to think about different stakeholder perspectives on implementation. But I'm going to encourage us to keep that in mind as we go through the talk today. So let me set the scene a little bit. I know the word engagement was in the title of my presentation, but I think everyone on this call knows that patient engagement has emerged as a key value in contemporary healthcare. And patient-facing virtual care technologies, those technologies that are designed for and intended to be used by patients, are really seen as tools to support that kind of engagement. And these are just newsletters, blogs, article snippets that I put here on this slide to convey that point. So patient engagement is the blockbuster drug of the century, a national action plan to support consumer engagement through e-health. Patient engagement is the holy grail of healthcare, using health IT to engage patients in their care. So this is all fine and good. What I would follow up and caution, though, in reading this sort of fanfare is that adoption of these kinds of technologies has proven very slow and also quite uneven across different healthcare organizations. Now, what you might say is, well, wait a minute, Tim, what about the COVID-19 pandemic? And, again, as I mentioned earlier, this surge in the use of virtual care technologies that we saw just in the last couple of years. So what I will say is that the onset of the COVID-19 pandemic certainly did drive a surge in the adoption of virtual care technologies across healthcare systems. That was certainly the case in the VA. So within the VA, veteran use of synchronous video telehealth appointments increased from about 10,000 to over 120,000 appointments per week between the months of February and May 2020. And that's about a 1,000% increase, which is staggering. However, that kind of surge was less apparent across other technology platforms. And again, going back to our experiences within the VA, the adoption and use of the VA healthcare system's mobile health applications remained limited during the pandemic and still remains limited. And that's what these cumulative use statistics are supposed to show in this table here. So as of April 2022, you can see that VA Video Connect, which is the VA's app that supports use of synchronous video telehealth, had over 2 million cumulative unique users. But when you look down through these other apps, you see this drop off, and you see that we have considerably less unique users of these different apps. I'm not going to go through all of these. If folks have questions about these apps, I'm happy to talk about them later. But again, highlighting the unevenness of the adoption of these kinds of technologies. So I know I've used this term virtual care and virtual care technologies. When I use that term, I'm really talking about technologies that are intended to enhance the accessibility, capacity, quality, and experience of healthcare for patients, their families, and their caregivers wherever they are located. And I know, just looking at the folks, in the audience today, I know there are a lot of folks who know the VA healthcare system quite well. I think there may be some folks who have a little less context for the VA. So let me just provide a little bit of helpful context here. So the VA is the nation's largest integrated healthcare system. We have over 9 million veterans who are enrolled for services with us. At any given time, we have about 6 million veterans who are receiving services through the VA healthcare system. We have over 320,000 employees, about which about 177,000 are clinical. We have over 1,200 sites of care. And the VA healthcare system has a long history of investing in health information technology to support its mission. Veterans who receive care through the VA as a patient population tend to be geographically dispersed. Our veterans live in highly urban areas. They live in highly rural areas. Many of them are users of multiple healthcare systems. So some get care through the VA, some get care in addition to the VA through community care, hospitals, other centers. Many veterans are faced with socioeconomic challenges, and many face unique healthcare needs. Some of those needs may be tied to their period of military service, but there's also a heavy burden of comorbid chronic conditions in the veteran population, which can contribute to unique kinds of healthcare needs. And then lastly, like other healthcare systems, the VA is facing this sort of unprecedented growth in the number and kind of virtual care technologies that are available to patients. So, when we talk about virtual care technologies, it's a big catch-all. And I really like this schematic from my colleague, Dr. Neil Evans. He is the director of VA's Office of Connected Care, which is responsible for the VA's digital health strategy. And he really uses these four large buckets to sort of describe VA's virtual care portfolio. So starting at the top of this schematic, we have the patient portal, which in VA is called My Healthy Vet. It's a tethered online patient portal that supports a suite of tools to support veteran communication, information access, and transactions with the VA healthcare system. Moving around to the left of this schematic, we have the VA's portfolio of mobile health apps. These are apps for both veterans and VA clinical team members. Many of them have been developed through public-private partnerships. I'm going to talk a fair amount today about an automated texting system. We consider that part of our mobile health suite of tools. Moving down to the lower quadrant here, our VA telehealth services includes various modalities, video visits, which I've already mentioned, but also remote monitoring capabilities and asynchronous store and forward technologies. And the last bucket on this slide is VA's Innovations Program. So the VA Innovations Program is a national initiative that allows VA stakeholders to submit ideas for healthcare system improvement. So this is sort of a way to solicit and generate ideas from frontline clinical staff and other stakeholders about ways to improve VA healthcare. And a lot of what we see come through the VA Innovations Program is ideas for new technologies. So that's why we include that in this categorization of VA technologies. And why does virtual care continue to be a priority for VA after so many years? As I said, VA's made this long-term commitment to using health IT to support its mission. Well, first, VA recognizes that virtual care has a lot of potential to address disparities in care, but we also recognize that if not implemented effectively, virtual care has the potential to exacerbate different disparities in care or to potentially contribute to the digital divide. Second, VA recognizes that there is this variation in engagement with virtual care among the veterans that we see for care. And we really need to understand why and how to enhance veteran engagement if we hope to realize the potential of this technology, right? So this is a problem that we have not yet solved. And then lastly, virtual care continues to be a priority for VA because there is this recognized and persistent gap in VA's understanding of what works for who and why in the veteran population when it comes to these kinds of technologies. And if we as a healthcare system are really going to use our resources optimally to advance the VA's mission to provide the best care possible to veterans, we need to address these gaps in understanding about when and for whom and why these different technologies work. So, VA as a healthcare system is on this journey towards virtual care implementation. And over the years, it has really leveraged its research and quality improvement arms that are embedded within the healthcare system to support that journey. I'm not going to go into a lot of detail about all of these initiatives, but I do want to mention some of these just to show you the breadth and longevity of some of this work. So in terms of major initiatives, so the eHealth Quality Enhancement Research Initiative program was established in 2011. That program was renewed as the eHealth Partnered Evaluation Initiative in 2015. That's the initiative that I lead. We also stood up a virtual specialty care query program in 2015. Dr. Weaver mentioned the Virtual Care Consortium of Research that was established in 2020. And in addition to those initiatives, VA has a robust portfolio of research studies that have been conducted and funded through VA's Health Services Research and Development Service. And I pulled this number just to give you a sense of that. So, a look back from the year 2011 to 2020, we just did this look back for some of our work in the Virtual Care Consortium of Research, and we identified just shy of 370 studies funded by VA's Health Services Research and Development Service that were focused on virtual care technologies. And, again, I'm going to dive into a couple of projects here in more depth now. Both of the projects I'm going to talk about today are from our portfolio of work that's being conducted as part of the eHealth Partnered Evaluation Initiative. And I just want to give you just kind of the big picture context of our objectives for the eHealth Partnered Evaluation Initiative. So first, our first objective is to demonstrate the impact of VA patient-facing virtual care technologies on outcomes that are important to patients as well as the VA healthcare system. And our second overarching objective in the eHealth Partnered Evaluation Initiative is to identify strategies to further the adoption of patient-facing virtual care technologies among patients and clinical team members in the VA. I'm not going to go through this slide in detail. What I just wanted to show was that since we were launched in 2015, we have pursued implementation and evaluation projects focused on a variety of different patient-facing virtual care technologies. If anyone is interested in the scholarly products that have come out of this work, please reach out to me, or if you reach out to Dr. Weaver, she can get in touch and I can get you the papers focused on some of these projects. One thing that I do want to mention here is that all the work we do as part of the eHealth Partnered Evaluation Initiative is designated as quality improvement. And that's a very intentional designation. We go through each fiscal year before we start a new scope of work. We go through a process where our projects are reviewed and determined to be research or quality improvement. And if we need to change our protocol to ensure they fit the criteria for quality improvement, we do so. The idea there is that the quality improvement designation allows us to do the work a little bit faster and to feed the results back into the healthcare system with a goal of sort of quickly realizing lessons learned and supporting implementation. So I said that when I started, one of the things that I was going to do was give us some thinking points to ponder as I step through a couple of our partnered evaluation and initiative projects. And that's the goal of this slide. And so I like to show this slide, and I'm never quite sure whether to call these sort of perplexing questions, when we think about the implementation of virtual care technologies, or wicked problems, but nonetheless, they are important considerations to bear in mind when we work in this domain. So first, when we're thinking about implementing and evaluating these kinds of technologies, how can we address needs for both effectiveness data and insights about implementation processes? Second, what implementation strategies work when and where for the different virtual care technologies that are out there? Third, what outcomes should be our focus? Fourth, what frameworks and models should guide implementation and evaluation work focused on virtual care technologies. And lastly, how do we understand potential unintended consequences associated with the implementation of these technologies? So if we have time at the end, we can come back to some of these, but I just, again, wanted to plant the seed with these for folks to kind of mull over as we go through these two projects. So let me turn our attention now to the first of the two projects. So this first project is entitled Automated Text Messaging with Patients in VHA Specialty Clinics, a Hybrid Type 2 Effectiveness Implementation Study. I'll give a shout out to our project team there as well. And I think as many folks on the call probably know, in the field of implementation science, there are study designs intended to combine both traditional effectiveness research with implementation research in an effort to speed the process from the development of clinical knowledge to people actually using that knowledge in practice, right? And so this idea of hybrid designs and hybrid designs types 1 through 3 are really defined based on the emphasis of a given project on either generating effectiveness insights or implementation insights. And I mentioned that our particular project was a hybrid type 2, so that means we were focused on both testing a clinical intervention for its effectiveness, but also testing an implementation strategy. So in this hybrid type 2 project, the virtual care technology that we were working to implement was VA's automated texting system. This texting system is grounded in evidence for automated tailored health messaging system. And in the way of the attributes of the system, it's a protocol-driven system. It supports one-way and two-way messaging with patients, and it can provide feedback to patients based on the responses they submit to the system. And the system is really envisioned as a way to help patients with particular care tasks, like appointment keeping or medication adherence. But it can also provide tips to patients, motivational messages to keep them engaged in care. And when the system was designed, it was really envisioned to provide different benefits for patients and clinicians. So in the way of intended benefits for patients, first, this idea of easy access on their personal cell phone. So compared to other VA patient-facing virtual care technologies, there aren't any special usernames or passwords required to use this texting system. And again, the idea that getting these kinds of text messages would be a way to promote patient engagement in their own care. And then second, for intended benefits for VA clinical team members, there's no requirement for VA clinical team members to send these messages or to read the incoming messages. When patients sign up to participate in this texting system, they receive some education and are asked to acknowledge a disclaimer that this is a self-management system and that their clinical team members may not necessarily be reading the messages. But clinicians have the option to do so if they want to. And again, this kind of system maybe has a lot of potential, right, to support patients to engage in the kinds of care plans that clinical team members are designing for them. So in this project, we chose to focus our work in the context of hepatitis C. We did so because Hep C treatment, again, as folks on the call probably know, involves a time-delimited, predefined course of daily medication that requires careful adherence as well as various kinds of follow-up appointments. So this seemed like a very appropriate context in which a technology like this texting system could be very helpful. So we designed a texting protocol intended to support patients through treatment for Hep C. The protocol included medication and lab reminders about upcoming appointments, as well as motivational messages to encourage patients to stick with their Hep C treatment. And the content of this texting protocol was created in consultation with Hep C clinical experts in the VA. So in terms of our overall objective for the project, we set out to evaluate the implementation and effectiveness of the automated texting system across VA specialty care Hep C clinics, and to test an augmented implementation strategy to facilitate more rapid adoption of the texting system Our work was guided by the Practical, Robust Implementation and Sustainability Model, or PRISM. And in the way of our methods, Hep C clinics were recruited on a national listserv and through a monthly national Hep C clinical conference call. We purposefully selected 7 clinics that expressed interest in the project based on a series of criteria, including their clinic size, complexity, and geographic location. And these 7 clinics were then randomized to one of 2 implementation strategies, either usual facilitation implementation or augmented facilitation implementation. And as you can see on this slide, usual facilitation involved training and resources that were provided by the automated texting system developers, calls with our team, with members of our team, to tailor the Hep C protocol to their local workflows, as well as access to an external facilitator who was available to these sites for consultation as needed. Augmented facilitation implementation, on the other hand, involved training and resources that were available from the texting system developer and calls with our team to tailor the Hep C protocol to local workflow. So just like the usual facilitation implementation sites. But in addition, these facilities also received proactive outreach by an external facilitator. And they were supported in identifying and preparing local clinical champions at their facilities to support the rollout and use of the texting system. And we also had a toolkit that we made available and provided to these clinical champions to support their efforts locally. To help us determine the effectiveness of the texting system in aiding Hep C treatment, 2 additional matched comparison sites were identified. They had similar size, clinic complexity, and were in similar geographic locations to the other participating sites. So in total, we collected data from 9 VA clinics in this project. So we had 4 that were randomized to the augmented implementation, 3 randomized to the usual implementation, and then these 2 comparison clinics. So we gathered a variety of qualitative and quantitative data to understand the implementation and effectiveness of the automated texting system in the way of implementation process measures. This included baseline and follow-up surveys from healthcare providers, activity logs, brief activity logs we asked providers to keep during the implementation period, and follow-up semi-structured interviews with providers. We gathered baseline and follow-up survey data from patients and also conducted follow-up semi-structured interviews with them. And we also asked our external facilitator to keep an activity log during the implementation period. So we had a window into the kinds of implementation activities and supports that were being provided to the sites. In the way of outcome measures, this included first, progress through what we call the automated texting system initiation cascade, which really represents 4 steps involved for a patient to begin using the texting system. And I have these 4 steps shown on the slide here. So first, the first step in this initiation cascade is that providers need to offer patients this texting system. The second step is the providers need to register patients and assign them this Hep C protocol that we developed for the project. Third, patients need to authenticate their phone number with this texting system. And then lastly, we hope when the messages start flowing that patients would respond to the text messages that they receive. And then lastly, we collected some measures specific to Hep C. These included patient self-reports of treatment distress and medication adherence. And we used data in the electronic medical record to assess sustained virologic response to Hep C treatment. So let's talk about some results. So first, across all of the Hep C clinics that participated, responses to baseline provider surveys indicated that provider characteristics were balanced on key factors including age, sex, and technology experience. The care teams across these sites were comprised of pharmacists, nurse practitioners, registered nurses, social workers. And across the Hep C clinics in the implementation arms, so again, the usual implementation condition and the augmented facilitation implementation condition, responses to baseline provider surveys indicated that there were no significant differences across these clinics on key factors, including readiness to implement the texting system, perceptions of the strength of evidence about texting, or the local implementation climate. So this slide probably conveys the most important take-home message from this first project. And what it shows is the number of patients who made it through each of the 4 steps of the automated texting system initiation cascade that I presented on the previous slide. So across all the 7 clinics that received the automated texting system, on the left-hand side of this slide, you see that a total of 625 patients started Hep C treatment during the implementation period in this project. But we see there's this steep drop in terms of the number of patients who made it through each subsequent step of that texting system initiation cascade. So again, moving from left to right on the slide, 197 patients of that original 625 across the usual and augmented sites were actually offered the automated texting system by their providers. 71 of those patients were actually registered and assigned the Hep C protocol that we created. 50 patients authenticated their phone numbers with the texting system, and ultimately 32 of those 50 patients actually responded to at least one of the Hep C text messages that they received. So again, the take-home point here is that we see this considerable drop-off across this initiation cascade. When we look at the steps in the initiation cascade by implementation arm, we see a somewhat different story. So this table shows the number of patients who were retained from one step in the cascade to the next by usual implementation group and augmented implementation group. And what we see here is that the patients at the augmented implementation sites seem to make it farther through the latter steps of this ATS, the automated texting system initiation cascade. So what about the data that we collected on implementation facilitation? So the period of implementation in this project was 10 months. There were 4 months of pre-implementation activity and 6 months of active implementation. And during that 10-month implementation period, we recorded a total of 293 facilitation events with a mean of 42 facilitation events per site. We did not see any significant differences in the number of facilitation events between the augmented and usual implementation sites. And this was a little bit strange finding for us. We would think that there would be more interaction and more facilitation events with the augmented implementation sites. What our team hypothesized here when we looked at this data, though, is that we think that because communication with the augmented implementation sites was very targeted, the fact that that communication was happening through a trained local champion, and that champions then conveyed information to other colleagues and other stakeholders at their sites, that this actually probably streamlined some of the communication, leading to this finding that we didn't see more interaction or facilitation events at these augmented implementation sites. So interestingly, providers at the augmented implementation and usual implementation sites expressed a fair amount of surprise about the high numbers of patients who essentially said, thanks, but no thanks, when they were offered the automated texting system to help them with their Hep C treatment. And from the log data that these providers kept during the implementation period, we saw that the reasons that patients offered for declining participation in the automated texting system really fell into 4 categories. And I have these 4 categories listed here. So first, the majority of patients who declined just expressed general disinterest. They just weren't interested in using the texting system to support them with their Hep C treatment. Second, patients reported an inability to text, or the texting was potentially cost prohibitive for them as a reason to decline participation. Third, patients reported already feeling like they were pretty good at adhering to their treatments, and that maybe they didn't need support from the texting system. And then lastly, patients cited beliefs that the texting system might duplicate other self-management techniques that they were already using to help them adhere to their treatments. And again, I include this quote from a provider that I thought was interesting, just sort of, again, expressing some of the surprise about these declination rates. So this is, again, from a provider at one of our sites. So, quote, "I thought a lot of people were going to be able to participate, but I guess when we started offering it, some patients don't. I guess they're not used to it. Most of the patients that I offer it to decline to participate." In terms of perceived usability and ease of use of the texting system among patients at the augmented and usual implementation sites who made it fully through the initiation cascade and responded to the text messages they received, perceived usability and ease of use of the texting system was pretty high. And that's what the bar graphs on this slide are intended to show. I'm not going to read all of these. But our semi-structured interviews revealed more nuanced insights into issues of usability and ease of use. And the call-out box here on this slide is a quote from a patient describing the challenge of grasping that this texting system really was not involving a real person on the other side. And that because of that, because they were texting with a system, with a machine essentially, they had to follow structured logic in their responses. So this patient said, quote, "Understanding that the system wasn't a real person, that I had to wait for the system to contact me before I could contact it." In terms of perceived usefulness of the texting system among patients who made it fully through the initiation cascade and started responding to messages, there was pretty much universal endorsement of the usefulness of the texting system. And again, you can see that in the bar charts here. And again, through the more nuanced data from our semi-structured interviews with patients, we learned that in some cases, patients were using this texting system to help them manage their medications beyond Hep C. So here's a patient who was saying that, quote, "I use the system for other medications as well. I group all of my medications together." And then in terms of the perspective of healthcare providers and perceived usability and usefulness of the texting system among providers at both the augmented and usual implementation sites, what this slide shows is that the texting system was perceived positively by most providers. Many reported that they intend to keep using it and that they felt like the system helped them offer patient-centered care. But it also shows that some providers had trouble getting started with the system, and that in the eyes of at least some, it added a lot of work to their day. And again, our qualitative data helped us appreciate some of the nuance here. This is a quote from a provider indicating the challenge of fitting the texting system in to the context of a typical clinic visit for Hep C. So I still think it's a challenge for me to make time in my clinical visits to have to pitch and then set this up, to set the system up. And in terms of Hep C outcomes, so our clinical effectiveness data, patients who texted self-reported lower distress about failing their Hep C treatment and better adherence to their Hep C medications compared to patients who did not text. And there were not significant differences in clinical effectiveness outcomes between patients based on use of the automated texting system in terms of medical record data. So for patients for whom lab results were available in their record, 96% of texters had achieved a sustained virologic response compared to 94% of non-texters with their Hep C treatment. So this is a lot of data. What do we make of all of this data? Just in terms of some synthesizing points. So first, this texting system was largely accepted and deemed useful by patients and providers who used it. We didn't see any significant differences in the number of facilitation events between the augmented and usual implementation sites in the project. Augmented implementation may help patients make it farther through the latter steps of that initiation cascade that I presented. But again, the main point here is the drop-off that we saw across those steps. Future implementation strategies probably need to focus on other approaches to supporting texting system enrollment. Some ideas that we presented back to VA leadership included supporting self-enrollment for patients or even creating prescriptions for patients to use the automated texting system. And then lastly, despite low yield, at scale, we still think this texting system could reach and has the potential to impact many patients. And again, thinking about long-term effectiveness, the potential for spillover effects when we think about the patients, for example, who were talking about how they were using the texting system to not only help them with their Hep C medications, but with their medications in general. So I do a quick time check here. I see we got about 15 minutes left. I'm going to move quickly through this second project from our eHealth Partnered Evaluation Initiative. And this second project is entitled the Veterans Engagement with Technology Collaborative Cohort. And again, I'll give a shout out to my project team here as well. And let me give you a little bit of context about what led up to the creation of the VetC project. So back in, I think it was 2016, VA leadership met to discuss creative efforts to develop ways to rapidly gather patient feedback on virtual care technologies and their implementation. And what emerged from those discussions were plans to create a cohort of purposefully sampled veterans who were willing to make a long-term commitment to providing feedback to VA on the latest patient-facing technologies that were available to them and helping VA understand the potential benefits of those technologies. We branded the idea of this cohort, the Veterans Engagement with Technology Collaborative Cohort, or again, the VetC cohort. And the overarching goal of this cohort, as I have on this slide, is to directly engage veterans in the evaluation of VA patient-facing virtual care technologies, and in so doing, create new insights and infrastructure to support their implementation and use. Our team was funded to recruit veterans into this cohort and to manage the cohort over time, and then to lead subsequent projects drawing on the members in this cohort. So in the way of methods, recruitment for the VetC cohort began in 2017. We focused our recruitment efforts at 14 VA medical centers across the United States. These facilities were selected because of their geographic locations, diverse patient populations, and as having reputations as either being medical centers that were early adopters of existing virtual care technologies or having high rates of adoption of existing virtual care technologies. In terms of veteran participation, veterans had to be at least 18 years of age, own a cell phone, and had used VA services in the last year to be eligible to participate in the cohort. Our goal, as I'd mentioned, was to purposely sample veterans who appeared to be frequent users of existing VA patient-facing virtual care technologies, and therefore might be more interested in participating in efforts like this one over time to improve virtual care technology implementation, on behalf of the VA and other veterans. Our proxy for use of existing VA patient-facing virtual care technologies was veterans having sent at least 5 secure messages in the last year prior to cohort enrollment. And this data on secure messaging volume is available in VA's corporate data warehouse. In terms of data collection, we've administered surveys to this cohort over time. The surveys have focused on a lot of different topics, We've merged those survey responses with VA administrative data, so we have a better understanding of the veterans' health conditions and diagnoses who are members of the cohort. And in terms of a snapshot of our status, so in 2017, when we administered the baseline survey to the VETC cohort, we engaged over 2,700 patients who completed that baseline survey. In 2019, we conducted our first follow-up survey, and we had 1,400 veterans complete a survey. And then in 2021, we completed a third round survey in which we had almost 900 veterans complete. So this is just an overview of the VETC cohort based on responses to the original baseline survey. And as you can see, the average age of the cohort members is 60 years old. It's a largely male sample. Most reported having some college education or higher. They're largely white, not Hispanic, and married. And you see a variety of chronic health conditions represented in the cohort as well. So what I'd like to do now is showcase one of our latest efforts with the VETC cohort, which was focused on soliciting feedback from cohort members to inform implementation strategy design. And as I think probably many folks on this call know, in implementation research, there's increasing recognition of the importance of stakeholder-informed strategies that can be used to support the adoption of interventions like virtual care technologies. And this commitment to foregrounding the perspective of key stakeholders is evident in discrete implementation strategies that are documented in the literature, right? So folks on the call may have heard about, engaging patients and consumers, using advisory boards, using work groups to support implementation. These are all ways to elicit input from stakeholder groups to inform implementation initiatives. And ensuring that healthcare systems deploy implementation strategies that align with the preferences and values of the populations they serve will, we hope, right, enhance implementation. So a focus of our most recent VETC survey that we administered in 2021 was understanding what is most important to veterans when they consider whether to adopt a virtual care technology to support their healthcare. So what did we do? So again, on our most recent VETC survey that we administered to cohort members, veterans were presented with a list of considerations, and we asked them, which of the following do you consider important when deciding whether to use virtual care technologies to help you manage your health? And veterans were asked to rate those considerations as very important, somewhat important, or not at all important to them. And this slide presents those considerations that veterans that were most frequently reported as mattering most to veterans in the VETC cohort when deciding whether to use virtual care technologies for their health. So we see receiving secure messages through the VA's patient portal from their healthcare team was endorsed 73% of the sample as very important. Knowing that my healthcare team members will use the information that I enter into these technologies, knowing that that information will be used to inform my care, that was endorsed as very important by 56% of participating veterans in the cohort. Having my VA doctor recommend these technologies to me, 52% endorsing is very important. Having somewhere where I could get help if I'm having issues with the technologies, a little over 51%. Having other members of my VA team recommend these technologies to me, percent of veterans in the cohort reporting is important, very important, excuse me, just over 45%. So what about those considerations that veterans reported as mattering least to them when deciding whether to use a virtual care technology for their health? So these were the considerations that were most frequently endorsed as not at all important to veterans in the cohort. So first, seeing information about those technologies on social media, 70.5% endorsing as not at all important. Having support in the community through veteran service organizations, churches, libraries, or other such organizations, a little over 66% saying that is not at all important to them. Having other veterans encourage me to use those technologies. About 57% said it's not important to them. Having help from family, friends, or other important people in my life. 41.6% said that that was not at all important to them when thinking about whether to use virtual care technology for their health. And then receiving printed information about those technologies from the VA. So again, what do we make of all this? I presented a fair amount of data very rapidly, but again, to help synthesize these sort of insights from the VETC cohort, it seems like based on these findings, recommendations from healthcare team members and knowing that one's data is going to be used by their care team is really important considerations for veterans when they're deciding whether to use a virtual care technology for their health, much more so than information they may encounter through social media, community sources, peers, or other sources. And we think that these kinds of insights are really the foundation that can begin to inform the design of more targeted implementation strategies to support the adoption of VA's virtual care technologies. And this is some of the work that's going to be ahead of us as we think about how to use this data in the months and years ahead. So this is really my last slide, and I want to just sort of say what again, where does all of this leave us? I talked today about virtual care implementation in VA. I tried to showcase to you a couple of recent projects that our team in the eHealth Partnered Evaluation Initiative has pursued to support VA on its journey towards virtual care implementation. And these 4 points are really just food for thought that I'd like to leave everyone with. So first, the search to identify effective implementation strategies for virtual care technologies has to continue. That's what this most recent effort to collect data from the VETC cohort was all about, trying to think about what implementation strategies may be best. Second, further work is needed to understand the types of patients that may be most likely to benefit from different virtual care technologies that are available. So again, what technologies make sense for whom and when along their care trajectory. Third, we have to keep accumulating evidence about the effectiveness of these technologies. So thinking about testing these different technologies in the context of different health conditions, in the context of different health behaviors. And lastly, we have to be increasingly attentive to the implications of these technologies and the implementation strategies that we design for addressing health disparities. So we hope lessening health disparities, closing those gaps, but we also have to be sensitive to the potential for unintended consequences and the potential that we may be having unintended consequences on disparities that we may see. So I'm going to stop here. I want to say thank you to everybody. I want to thank Dr. Weaver for the invitation to join you all. I know we've run up close to the top of the hour, but we still have, I think, 3 or 4 minutes to talk about questions. I'm also happy to talk with folks offline. I have my email address here, and Dr. Weaver certainly knows how to find me as well if folks want to connect after the session. But I do want to say thank you again for letting me present today.
So thanks so much, Tim, for your presentation today. I think we can take 1 or 2 questions. Just go ahead and unmute yourself and go ahead and ask.
Hi, this is Holly Kramer. Thank you so much for the really great talk. I have a question about the first project you did and how you compared the implementation. Is that kind of like a typical strategy for comparing 2 implementation arms, is use like a standard one and then you have an augmented one? Is that usually like you add more stuff to it, or could it be like you do something completely different?
Yeah, so Holly, it's good to, let me turn my video back on here too, sorry. Let's see if I can get this going. It's good to see you, Holly. So yeah, what I would say is, typically now when we think about testing implementation strategies, it's common that you're thinking about two intentionally designed bundles of strategies, right? So we call them like multi-component strategies that you're comparing. But typically what you want to be thinking about is, are there active ingredients that you want to compare sort of one against the other that you think might make one strategy more effective than the other? I think in terms of thinking about like usual care or sort of usual implementation, I think we see less comparison to sort of what we would call usual care. What we called usual implementation in that first study, there was sort of an implementation program that was provided by the VA. So there was a sort of strategy that the VA provided. What we then did was sort of enhance that with a facilitator and coaching.
I know there was a lot of information that Tim presented, a lot of very good, useful information. But if you have questions for Tim, we're at the top of the hour, please reach out to him directly or reach out to me and I'll connect you guys. And thanks again. Everyone have a great afternoon.